Hello, thanks Manos and Manos again for the great congress. So which are the complications after Latarjet and how can we reduce them? Those are my disclosures, not related to this talk. Latarjet, as we heard today, is one of the best stabilizing procedures and is so good that some of the speakers, as we heard today, they use it in more than 95%. But still, those speakers are very experienced, and in mostly of the normal surgeons, it may produce quite different results than those cited into these articles. The things we are afraid about are complications, and complications can be very severe, and especially if they happen in a young population, this could be a disaster. The first things when we start talking about the Latarjet are the patient selections. As we heard today, the degree of bone loss is one of the main indications for the Latarjet procedure. And numbers are changing. The lower one are around 15%, but in this video that is currently running, we saw a huge bone loss on the glenoid side. Almost half of the glenoid is missing, and mostly also big, huge heel sacs lesion. So this is not the right indication for the Latarjet. And if we combine it with the Latarjet, like remplissage in these conditions, we will end up with stiff shoulder and arthrosis. So other procedures are more indicated. The second video, it's now running. It's a young patient, hyperlax patient, voluntary multidirectional instability and subluxator. She felt and produced anterior Bankart. So what kind of procedure we can do in this patient? Again, Latarjet, it's not the right procedure for this patient. And the picture on the right, we see just the sequela. It is an epileptic, bed-treated epileptic patient. After a few years, he developed bilateral arthrosis, and now the next procedure will be the arthroplasty. So this is another patient. Now she's 40 years old. She was voluntary posterior subluxator who felt, and she was treated 3 times till now. The first 2 procedures were posterior osteotomy of the glenoid and Bankart. Both failed. The second procedure was Latarjet. And this is now the final result. We have stiff, painful shoulder that is still able to subluxate. So now what are we going to do in this patient? Probably we will end up in reverse, but again, we still don't know how will be the final result. This is an interesting case I found. Was the first arthroscopic Latarjet performed in our country in 2007 by one surgeon from Annecy. Now he moved from Annecy, now he's working abroad, and today he's with us. And he performed this procedure in 2007 during one arthroscopic course. And at that time, the patient had already some degree of arthrosis, because we can see osteophytes on the humeral head. And interestingly, in 15 years, the progression was arthrosis were very slow. And I called this patient, made a video of him, and we can see quite a good range of motion. Okay, he has some crepitus, but still, we don't know which is the degree of arthrosis preoperatively that is still acceptable for the Latarjet. And secondly, we don't know how fast the arthrosis will progress. So several steps are still missing in the puzzle. Okay, once we found the right patient, we can start with the procedure. But unfortunately, we are unable to work alone. We need some help, and the help are anesthesiologists. So we can work in general anesthesia or interscalene block. General anesthesia have some problems, and those are the patient may get sick after the procedure, the pain is not well controlled, so we can choose for the interscalene block. If something went wrong with the interscalene block, we might have severe problems. This is a young patient treated for the Latarjet with just interscalene anesthesia, but after 1 day, the anesthesia still was working. The second day, still the patient was unable to move her arm. The third day, the surgeon got nervous. And the first thing he called the anesthesiologist and asked him, did you have some problems when you performed the scaleni? And the anesthesiologist said no, I perform 500 scaleni per year. Are you doubting about me? What's wrong? And then the first thing you usually the surgeon do, called the MRI, to do a MRI of the interscaleni region to see if there is some bleeding, some hematoma. But usually the anesthesiologist is faster than you. He knows better than you the radiologist. He will call faster than you and explain what's going on. So once you call the radiologist will check the MRI and said, no, everything is okay in the neck, but probably it's your fault because you did a mistake when doing the procedure in this area, because the anesthesiologist said me like that. And then start the war between you and your anesthesiologist. But the problem is that in the middle, there is a patient. And you will have to look at the patient and explain him and follow up him and so on. Fortunately, all those neurologic problems in mostly of the case are transitory and disappear. Unfortunately, in this case, it wasn't like that. So there will be quite a challenging case. Once we choose the right patient, did the right anesthesia, we can do the procedure. The procedure have several steps that may go wrong. We heard about today something. I put just 3 of them. Coracoid preparation. We can do the resection to posterior, end up with a so famous spike on the coracoid, and this spike may make some problem on us, usually is bleeding. We may have a breakage of the coracoid and end up with a small coracoid, and finally just 1 screw. When we release the conjoint, we may damage the musculocutaneous nerve if we go too distal. When we perform the subscapularis split, we may damage the tendon, so we must be very, very gentle to the subscapularis because those kind of complications are very, very difficult to treat. And at the end, screw position, we can put them to medial, to lateral, to oblique, or like in this picture, directly into the articular surface. Fortunately, this one was removed immediately postoperatively. Once we finish the operation, we should rehab the patient and follow them. In the left video, both videos are made 4 weeks after the procedure. On the left side, we can see a skater, so extremely motivated guy that have quite perfect range of motion, but for 4 weeks it's too much. So we should slow down somehow those kind of patients. On the right side, also at 4 weeks, we can see a patient that is stiff, and this stiff patient end up with low-grade infection. It was a Cutibacterium. We give him antibiotics. His mobility is quite good now, but on one follow-up, after 2 years, we found out a complete resorption of the graft. And interestingly, that now he have full range of motion, and he refused another procedure to take out the screws because he said, I'm perfect. Now we know why this procedure works and why the patient is still completely stable, because the tendon is completely ingrowth into the subscapularis. So we see it several times during the revision surgery, and we are not afraid about that. What about the long-term complications? Something was said. This is arthrosis. We know that the older is the patient, or at least his biological age is high, the higher is probability to have arthrosis. If we put the screw too lateral or the coracoid too high, we may have arthrosis. If the patient have dislocation, we should treat them as soon as possible, because the more dislocation he will have, the higher is the probability that he will develop arthrosis. And also we know that Latarjet in high demand sport active patient lead to arthrosis sooner. In conclusion, if you want to have a good result, you should find the right patient, and this is the most difficult step. Why? Because to do this step, you need a lot of knowledge. You have to follow strictly the current indication, and they are changing the indication for the Latarjet. you should be friend of your anesthesiologist and trust him, because every shoulder procedure is a team procedure. When you do the procedure and when you start with the procedure, you always need someone behind you and next to you that follow every step you do, not to do mistakes. And at the end, you should follow the rehabilitation and follow up your patient strictly. In that way, if you find any complication, you should treat it immediately. Thank you.